Hi, welcome to our lesson on HIV and AIDS. This is an exemplar that falls under the concept of immunity. So just as a reminder, immunity is the body's natural or induced response to infection. So most of the other exemplars that we talk about with this concept in this class are autoimmune disorders. HIV is not an autoimmune disorder. It is an acquired immune disorder. It comes from the HIV virus. So just for a little bit of history, this virus was first reported in June 1981. So this is a fairly new virus. Most of you probably weren't around in 1981, but this was considered a worldwide pandemic, and it's still continuing on today. So this virus has a very long onset. Eventually, it can lead to the disease process called AIDS, which is acquired immunodeficiency syndrome. It doesn't always lead to AIDS, and our goal is to prevent it from developing into AIDS. But this is a virus, and like every other virus that exists, it's constantly changing and adapting. So we're always trying to get ahead of it, and it's always one step ahead of us. But it is considered now a chronic condition because we're better at managing it than we used to be. So try to think of this almost like somebody having diabetes, that if they're managing their care, they're taking their medications, they can have a normal life expectancy and live a fairly normal life with, some few precautions that might be a little bit different than somebody without HIV. So this is a virus. Viruses usually replicate inside of cells. This virus in particular replicates inside of the T helper cells, which are white blood cells, especially those with CD4 that are CD4 positive. So the initial transmission, once somebody acquires this virus, they might not even realize that they've acquired it. They have an initial reaction where they feel sick, they might, have a fever, have flu-like symptoms, and then they recover from those symptoms. So a lot of times, they might just think, I got a really bad cold, or I had the flu, and they may not realize that they've actually contracted HIV. After that, they go into this asymptomatic phase, the latency phase, where the virus is replicating inside of those T cells, but they're not having a lot of symptoms from it. They can be in this phase for a very long time, up to 10 years. And again, they may not know that they have HIV at this point. So unfortunately, a lot of times, the people who have HIV, this is the point where they're transmitting that infection onto other people. 10 years is a very long time not to realize that you have something. Then they may have this period of symptoms where their CD4 count drops, and they start feeling the symptoms of HIV, where they may have weight loss, nausea. The last stage, which is the terminal stage, is AIDS, and that is when the CD4 count has dropped below 200, or they have some type of what we call an opportunistic infection or disease process, like an opportunistic cancer. What that means is that this person has now developed some type of cancer, or they've gotten an infection that you wouldn't typically get if you had a healthy immune system. And then that infection or that cancer is what eventually leads to the death of that person. So, like I said, we're not ahead of this disease process yet. It's still always one step ahead of us. It's constantly changing and adapting to the medications that we have and our treatments. So 2 million people have been, just in the U.S., have been infected since 1981, which led to 600,000 deaths. So right now, about 1% of those in the U.S. are living with HIV, and 15% are unaware that they have it, which unfortunately means that they could be spreading it. Those that are most commonly affected are homosexual men and black men. So that is a risky age group, especially those that are having these high-risk behaviors, the unprotected sex and the IV drug use. Those are the biggest risk factors because this virus is transmitted through body fluids, so blood and semen, and vaginal fluids. So unprotected sex is going to be the biggest risk factor for developing this or contracting this. And then dirty needles also. There are some other risk factors, like being a healthcare worker is a very, very tiny risk just because you may come into contact with dirty needles. But that risk is so small that really these are the top two risk factors nowadays. Some of the clinical manifestations, and this is going to be after that latency period, so this might take a long time for them to start developing these clinical manifestations. They may have low-grade fever, a cough, feeling weak, feeling nauseous, having some diarrhea. None of those symptoms would make anyone think, oh, maybe I have HIV. So a lot of times, that can go on for a long period of time before they figure out what's going on. Maybe some trouble swallowing, some forgetfulness. Eventually, they may start to see some skin lesions or lesions in the mouth and the throat. They may have some shortness of breath, develop headache, vision changes, night sweats, and then lymphadenopathy is the swollen lymph nodes. There are a few different diagnostic tests for HIV. If somebody is high risk for developing HIV or contracting HIV, like those that are high-risk behavior, they're having unprotected sex, they're active IV drug users, they should be getting screened every 3 to 12 months to see if they've developed this. General population doesn't need to do that, those that are not having those high-risk behaviors. The way that we diagnose HIV are through the detecting the HIV virus antibodies in the blood. So if somebody just came into contact with HIV, they may not have those antibodies in their blood yet. It may take up to 6 weeks to start developing those antibodies. So if somebody's just come into contact with that virus, they may not have a positive test for a while. Once somebody's been diagnosed, every 3 to 6 months, at least for the first couple of years, they're going to be getting a CD4 count. Because like I said, we're trying to keep that CD4 count as high as possible. Because once it drops below 200, that's when we diagnose them with AIDS. And then even if they get that CD4 count above 200, once they have that diagnosis of AIDS, we can't go back and say, okay, you don't have it anymore. They carry that diagnosis with them. We may also get a viral load, about every 4 to 6 months for the first couple of years, just to see how that virus is replicating in the body. It will help us to determine if the medications we're using are working or not, because we want the viral count to be low and we want that CD4 count to be high. If we can manage that, then we know that we have this person on a good medication routine for the particular virus that they have. Because like I said, HIV is not the same in every single person. So one person's HIV may be resistant to certain medications while another one's is not. That's also why it's important that even if you have two partners who are exclusively sexually active with just each other, they should still be using barrier protection because they may have different strains of this virus. Some of the medications, if somebody is living a high-risk lifestyle or if they know they've just come into contact with this virus, they can take a pre-exposure prophylaxis to hopefully prevent contracting that virus. Prophylaxis is for people who already have HIV to prevent them from getting other super infections, other viral infections, or things like that. Antiretroviral therapy is what this person is going to be on for life. We'll talk more about specifics on this, but just know that these are pretty harsh medications. They have a lot of side effects that are pretty unpleasant. So people don't necessarily enjoy taking these, but they have to be compliant with these medications. If they start and stop, then that virus will eventually become resistant to that medication. So that, then they start running out of options for what to take. Sometimes we wait to start this antiretroviral therapy until we know we have a person that's going to be compliant to taking it. Because once they start this, they can never stop it. Sometimes that's a hard sell. especially if somebody's in the latency phase where they don't have a lot of symptoms, that, okay, now you're going to have to take something for the rest of your life, and maybe it doesn't make you feel so good. So we have to make sure they really understand and are ready and willing to do this. And then, of course, they need their immunizations because they're immunocompromised. So they need to be up to date on their vaccinations, not the live virus vaccines, but everything else they should be up to date on. So there's lots of complications. The biggest complication is AIDS. We want to prevent them from developing AIDS. So some of the opportunistic infections are here. Not all of them. There's an endless amount. But PCP pneumonia is pretty common for those with AIDS. Sometimes they don't even realize that they have this until they show up to the hospital really sick with one of these things, and that's when we make the diagnosis. Kaposi sarcoma is something you don't typically see anywhere else other than somebody with AIDS. It's like this dark purpley rash. It looks like a rash, but it's a form of skin cancer. And then these are some of the bacteria, viruses, parasitic, and fungal infections that you may see in somebody with HIV. And if they have AIDS, this is what we're trying to prevent from happening. So toxoplasmosis is something that, it can be found in like goose poop. It can be found in cat poop, or in cat urine. So we want to make sure that they shouldn't be changing the litter box if they have AIDS. We want to make sure they're getting TB checks regularly because they're super high risk for developing tuberculosis if they're anywhere near it. And then herpes zoster is another just opportunistic infection that kind of latches on to that weak immune system. So a lot of things that we need to be teaching this patient. They're at higher risk for every other type of infection there is, so we've learned already from Module 1 and 2 different types of infection control protocols, so we need to be teaching them that at home. Make sure you wash your hands really good. If they have AIDS, they shouldn't be eating fresh fruits or vegetables. They should be cooking those things. Maybe don't use pepper and paprika because they carry a lot of viruses on them or bacteria on them. If you have a patient in the hospital with HIV or AIDS, you should only be using standard precautions. There's no need to be wearing gloves every time you touch them. It's only if you come into contact with their body fluid. So a good rule of thumb is to treat everybody as if they have it, because a lot of people that have it don't know that they have it anyway. So, and then we need to teach them about how this virus spreads. So if they're having, intercourse with somebody, they should be using barrier method birth control. They can't just take birth control pills. They need to provide a barrier because that virus spreads through body fluids. So even if they're with the same partner all the time, if that person, if they have different strains of the virus, they should be using barrier protection. So this is just a quick snapshot of this disease process. So we're going to talk about this more in class. So please make sure you do your prep work, do your readings, and then we'll talk about this once we're all together.